Hello, everybody. Thank you very much for inviting me to speak. I'm sorry I cannot be there, and I look forward to the time when we will be able to meet face to face. I will start my presentation. The title of my talk is Essential Pain Management: What's New in 2022? Globally, 5.5 out of 7 billion people do not have access to treatments for moderate to severe pain. This is data from the WHO, and it's very similar to the Lancet Commission on Global Surgery's finding that 5 billion out of 7 billion people do not have access to safe and affordable anesthesia and surgical care when needed. During this talk, I'm going to give an overview of the global burden of pain. I'm going to look specifically at some of the issues related to opioids. I'll then give an overview of the Essential Pain Management Program, EPM, and cover some recent EPM developments, including EPM Online. I am a co-author of Essential Pain Management, and I will be discussing the course that I co-authored during this talk. There is a large global burden of pain, and it is useful to think of pain under these three headings: acute pain, cancer pain and palliative care, and also chronic non-cancer pain. As anesthesiologists, we are most familiar with acute pain. So we see pain after surgery. We also see pain in trauma patients, women having babies, and in some low resource settings, there is acute pain due to sickle cell disease, for example. Surgical disease and trauma accounts for 30% of the global burden of disease. So every year, a very large number of people worldwide will have pain due to surgical disease and trauma. Turning to cancer pain and palliative care, we can think of both cancer and non-malignant life-threatening conditions like HIV/AIDS. In low resource settings, there is often late presentation with cancer, and there may be very limited treatment options. It's estimated that around 9 million people die from cancer each year globally. The third category is chronic non-cancer pain, and this is a very diverse group of diagnoses. It includes pain like back pain, headache, pelvic pain, diabetic neuropathy and other neuropathic pain, arthritis, amputation pain, including phantom limb pain, and chronic post-surgical pain. But this is a very big list. The prevalence of chronic pain in low and middle income countries is at least as high as high income countries. In 2010, I visited Papua New Guinea in the West Pacific. At the time, I was a postgraduate examiner in anesthesiology. And I met this little girl who was 13 years old at the time. She had metastatic Ewing sarcoma. So the tumour had started in the lower part of her femur and it had spread to the spine, and she had severe pain. When we asked her to rate her pain, she said 10 out of 10. We asked the health workers in the ward, the cancer ward where she was staying, what treatment she was receiving for pain. And they told us she was getting nothing. She wasn't even getting paracetamol. And there wasn't also a lot of thought being given to some non-pharmacological options for managing her pain. So one of the problems that we saw in this ward was that the healthcare workers really were at a loss to know how to manage this girl's pain. They didn't have a system for managing her pain. And what we've seen repeatedly in many countries around the world, both low resource countries, but also richer countries, is that there are a lot of barriers that prevent pain from being managed as well as it could be. There may be low prioritisation of pain relief. It's just not seen as a priority by hospital authorities or people higher up. Patient expectations and attitudes may affect pain management. Patients may not expect to receive pain relief. And there may be attitudes that pain makes you stronger. There may be poor staff knowledge, and the staff may not see pain relief as a priority. There may be staffing problems, very low numbers of healthcare workers. And there can sometimes be poor access to analgesic treatments, both pharmacological and non-pharmacological. There are often specific issues related to opioids, whether they're available or whether there is appropriate prescribing. And there may be other barriers. There may be a lack of data and research, and there may be additional costs for patients who wish to seek pain relief. So here are three of those barriers that often seem to be very important. Pain relief may simply not be prioritised. There's often poor staff knowledge and attitudes, and there can be very difficult issues related to opioids. Looking at opioid issues in more detail, one of the big problems worldwide is that there is restricted availability in low-resource countries. In fact, 80% of the world's population receives only 10% of the world's opioids. Or to flip this over, 20% of the world's population receives 90% of the world's opioids. In some settings, there may be a lack of specific preparations, for example, oral morphine, even though we know that oral morphine is a very useful preparation for treating pain in children and for treating cancer pain. In many settings, there is underprescribing, and sometimes this is due to opiophobia or the exaggerated fear of side effects. Sometimes health workers think that a patient will become addicted after a single dose of opioid given appropriately for pain management. There's also the other problem of overprescribing and illicit use, and in some countries, the inappropriate use of opioids in chronic non-cancer pain. Thinking more about the availability of opioids in different parts of the world, this is data from the University of Wisconsin, which divides the world up into WHO regions. On the y-axis, we have the total opioid consumption in morphine equivalents in milligrams per capita per year. The average for the Americas, both North America and Latin America, is around 200 to 300 milligrams per capita per year. For the United States, it is 700 milligrams per capita per year. Europe is also high, but look at the African and Southeast Asian regions. They barely make it above the baseline. Very little opioids are used in these regions of the world. In 2017, the Lancet report, or the Lancet Commission on Pain Relief and Palliative Care released its report. And in the report was this graph. It shows consumption versus need. The size of each country is proportional to the amount of opioid consumed divided by the burden of painful disease as represented by cancer and HIV/AIDS. So the United States and Canada have a very high opioid consumption. They also have a relatively smaller burden of painful disease. But look at Africa and parts of Asia. These have been reduced to lines on the map. And this is because they have very little opioid consumption, and they also have a high burden of cancer and HIV/AIDS. There's a major problem with overuse of opioids, causing harm in some countries. This news report came out just a few months ago. In 2021, the US surpassed a record 100,000 drug overdoses, causing death, and for the first time ever. And this was mainly due to fentanyl overdose, but there was also overdoses due to oxycodone. The Centers for Disease Control and Prevention released these figures for 2020, which showed the poisoning deaths to be close to 100,000, and most of these were opioid overdoses. And this compares to just over 40,000 road crash deaths and about 45,000 firearm deaths. So we have a major problem with pain worldwide. There is a massive burden of pain around the world. And we need education that provides basic pain knowledge. Knowledge that improves assessment of pain and also improves the use of multimodal analgesia. We also need to emphasize that good pain management requires a team approach. And we need to address opioid issues, misconceptions or opiophobia. We need to give people the tools to advocate for greater availability. And we also need to make sure that opioids are given when indicated, but also not given when they're not indicated. We do not want opioids given for pain where they are unlikely to be effective. Not all pain is the same, and the International Association for the Study of Pain within the last few years has refined their definitions of types of pain. And the IASP now talks about nociceptive pain, neuropathic pain, and nociplastic pain. Of course, nociceptive pain is the type of pain that we are most familiar with. It's pain where there is an obvious pathology, for example, fracture, appendicitis, or pain due to arthritis. Neuropathic pain involves injury to the nervous system. So examples here are diabetic neuropathy and amputation pain. Nociplastic pain is more difficult to define, but it includes examples such as chronic back pain and fibromyalgia, and there is no pathology easily identified. But for the purposes of basic pain management, simple pain management, for most providers, we don't need to talk about nociceptive, neuropathic, and nociplastic pain separately. What's important is to divide pain into nociceptive pain and non-nociceptive pain, which comprises neuropathic and nociplastic pain. The traditional pain treatments work well in nociceptive pain, but morphine is often unlikely to be useful in non-nociceptive pain, and often non-pharmacological treatments have greater importance. This brings me to the Essential Pain Management Program, or EPM. In EPM, we use a simple learning aid called RAT, R-A-T, which stands for Recognise, Assess, Treat. EPM is a face-to-face workshop or now an online course. Usually involves doctors, nurses, and other health workers, so it is multidisciplinary. And the course provides a simple system for managing pain and also a system for teaching others about managing pain. Just to expand RAT a bit more, the first part of the process in pain management is to recognise the patient has pain. The second part is to assess the pain. How severe is it? What type of pain is it? And are there other factors involved? And finally, treatment consists of both pharmacological and non-pharmacological options. So how does EPM work? I think it has 3 pillars. It's a very simple system. We use a lot of case discussions, and there is local ownership. This man is Richard Branson, the founder of Virgin Airlines, and he said this statement a few years ago: any fool can make something complicated. It is hard to make something simple. I think it is always important with educational resources to start with a simple framework, to start with something simple and then build complexity on top of this, rather than starting with something more complicated and trying to make it simpler. So EPM provides a very simple system for managing patients with pain and also teaching others about pain management. KISS, or KISS, stands for Keep It Simple, Stupid. The second part of EPM is that we use a lot of case discussions. So these, during this discussions, a multidisciplinary group will talk about how they would manage particular cases in their own environment, using the resources that they have and applying the RAT approach. The third pillar is local ownership. So when we are holding a face-to-face course, we start with a one-day EPM workshop. Usually this is followed immediately by a half-day instructor workshop involving some of the people who attended the first day workshop. And then immediately, usually on day 3, the new instructors will teach on another one-day workshop. So we're really devolving responsibility to local clinicians. And the advantage here is that these people become pain champions. They seek local solutions for local problems, and they act as very good role models for other healthcare workers in that local context. The first EPM course was held in Papua New Guinea in 2010. In the last 10 years, the course has been held in more than 60 countries worldwide, and we have lost count of the number of participants, but it is probably somewhere between 10 and 20,000 people. One of the reasons we have lost count of the number of participants is that local ownership now rests with many of the local clinicians, and we don't always hear about courses being run locally. Just to turn to some new developments, a few years ago we developed the EPM app, which is available for iPhones as well as Android phones. This provides some prompts and a structure for assessing patients, and it also provides a detailed and useful formulary. This app is available for download for both platforms for free. And then a couple of years ago, at 2021, at the World Congress in Prague, we launched the Essential Pain Management online course. This course has been recently updated and is available for free online. We're excited about this course. The materials have been extensively revised. We have also clarified some of the definitions and the way that we teach the material. And the course includes some short videos, also some quite innovative teaching techniques. There is a number of cases and role plays during the course, and there are a set of quizzes which must be passed to progress to different parts of the course. This course normally takes about 2 or 3 hours to do, and as I said before, it is free online. I'll give the address in a couple of slides' time. So, key messages from this talk. There is a high global burden of pain, and it is useful to think of pain under the headings of acute pain, cancer pain and palliative care, and also chronic non-cancer pain. We need a sensible approach to opioids. There are many countries that do not have access to enough opioid, but there are also examples where too much opioid is being prescribed or used illicitly, and there are also places where there is opiophobia, an exaggerated fear of the side effects of opioid administration. Simple multidisciplinary education is needed, and EPM is an example of a teaching resource, an educational resource that can be used for this type of education. We've not only developed the EPM app, but we now have the EPM online course, and this is freely available. So for more information, please go to www.essentialpainmanagement.org. This has more information about the course and also has manuals for download. I'd also encourage you to look at the EPM online program. There are links in the essentialpainmanagement.org website, or you could take a photo of this QR code and go straight to the website. Thank you very much again for inviting me. It's an honour to speak at this Congress, and I wish you all the best for the rest of your meeting. Thank you very much.